Welcome to this special day today. We have a greatest pleasure to present Professor Anderson, who will tell us a little bit more about anomalous venoatrial connections. So Professor Anderson, he doesn't need an introduction, but I have done some exploration in his career and amazing things came out. So Professor Anderson started with cardiac morphology and cardiac anatomy in 60s in University of Manchester, then University of Liverpool, then moved to Great Ormond Street, and currently still has connections with USA, UK, and the rest of the world. Is most popular speaker nowadays, and I will be looking forward together with you to host him today for this talk. Thank you for coming, Professor Anderson.
Well, it's my pleasure to be with you all. And as Mirjana has told you, today we're going to be discussing abnormal venoatrial connections. In fact, when we started our discussions, Mirjana asked me if I would talk about cardiac development, because I know that most of you are particularly interested in cardiac development. And although I'm allegedly retired, it's quite some time now since I retired from Great Ormond Street. 2007, time grows increasingly swiftly, but in my alleged retirement, I've been doing quite a lot of work with regard to cardiac development. And in this COVID pandemic, I've also been making several presentations about cardiac development. So I didn't want to repeat what I had done previously. And so for any of you who are interested, you can gain access to the presentations that I've already given during this period of lockdown on cardiac development. There are 3 specific presentations that are now hosted on the website of the Heart University. I did these on the basis of the meetings like this being organized by the Congenital Heart Academy, and those are now available, as I say, in the Heart University. And you have to register for the Heart University, but if you do that, you'll find my 3 presentations there. So I'm going to expand from what is available there to talk to you today about abnormal venoatrial connections. And as we move into my presentation, you'll see that I'm going to emphasize for you the normality of the venoatrial connections, because it's axiomatic. If you don't understand normal anatomy, you're never going to understand abnormal anatomy. But what I'd also like to do is to show you how, in this particular setting, abnormal venoatrial connections, if we understand normal development, that gives us a very good means of understanding what goes wrong to produce the congenital malformations we're going to be discussing over the next 40 minutes or so. So, normal development. It's interesting that Mirjana told you that I started my career in Manchester a very long time ago now, in the 1960s. And when I first started in the field of cardiac anatomy, at that time, I was also very interested in cardiac development. But at that time, cardiac development, knowledge of cardiac development, was largely speculative. And we looked at what we thought was the normal development of the heart, and much of that was deduced from our knowledge of cardiac malformations. So in many ways, we were putting the cart before the horse. Nowadays, that's not the case, because nowadays we know very well what is happening during normal cardiac development. And we also know that what happens when some of those mechanics of normal development go wrong. And that's very much based on our reconstruction of the Carnegie collection of human embryos. The original reconstructions of the Carnegie collection also go back a very long time. They were first done in the 1920s. And it was on the basis of these reconstructions that embryologists in the United States, working in what was then the Carnegie Institute, set up this means of categorizing the stages of development of the human heart. we now can go back and we can look at human embryos now, which have been serially sectioned, and we can place them within this catalogue of development. And that's what I'm going to do today as I discuss with you the changes that occur during normal development. And I'm able to do this because I've been collaborating over the past 6 months or so with a very old friend of mine, Wout Lammers, who was initially the professor of anatomy in the University of Amsterdam. He then moved to take up a similar position in the University of Maastricht. And he has a much younger anatomist working with him, who's called Jill Hickspoors. Jill just presented her doctoral thesis on cardiac development. They're also specialists on all forms of development. And they have reconstructed the series of human embryos on which I am going to base the material that I present to you today. And it's quite surprising because they have reconstructed embryos that go through the overall series of development. So this is one of their initial reconstructions. It's a very early stage. It's 4 weeks after conception. And this doesn't look much like an embryo or even much like a heart. What you're seeing is they've reconstructed here in yellow the neural plate. And what you see here is that that is opposed to one of the nourishing areas of the developing embryo, the yolk sac. Coming into the yolk sac and bringing in the nutrients, in fact, from the mother is the umbilicus. And there they've reconstructed in brown the pericardial cavity, and the heart is developing within that pericardial cavity. Now, the beauty of what they've done in their reconstructions is they've prepared them in such a way that you can take away the different parts and you can look at the developing circulation. So this is exactly the same embryo. I've taken away those parts representing the yolk sac, the pericardium, the neural plate, and I'm showing you now the developing circulation. And there, within the pericardium, is we have the 2 tubes that at the moment are no more than endocardial tubes, and they will form the basis for the heart. You note there are 2 of them. Eventually they will merge and produce a solitary heart tube. At the back, running down the back of the neural plate within the body of the embryo, we have the aortas, and here we have the venous plexuses that we're going to be particularly concerned with today as we look at the way the heart all comes together. So if we move on 1 stage, this is going from Carnegie stage 9 to Carnegie stage 10, the embryo is still very much like a plate or a disc rather than the typical arrangement when it starts to fold. In fact, we can see the beginning of what we call folding at the head end of the embryo. The neural tube is bending forwards, and this eventually will become the brain. So again, I've taken away the outside parts so that you can see the developing circulation. I've turned it a little bit, so you're looking at it from the front. This is another beauty of the reconstructions made by Jill and Wout, that you can turn them any way you want. But now within the pericardium, which to your left hand is still colored by brown, we see what has happened to those endothelial tubes. They've come together now and they form the cavity in the linear heart tube of what will primarily become the left ventricle. And this is derived from what we now call the first heart field. But also growing into the pericardial cavity are migrations of cells from the heart-forming areas. And at the cranial end of the developing heart tube, we have what we call the outflow tract. But what we can now see at the caudal end, which will become the venous pole of the developing heart, are the inflows within the pericardial cavity. And coming together now and forming those venous inflows are the veins that are coming back from the yolk stalk. We call those the vitelline veins. On either side, we also have veins that are coming back from the placenta, from the mother, and these are the umbilical veins. As yet, however, we have no formation of any venous channels that are coming back from the body itself. We're going to see those very shortly at the next stage of development. And this is the beauty of having the access to these reconstructions. We can see the temporal changes that occur within the pericardial cavity in the heart, but also in the venous channels that are coming together to form the venous inflows. So now I'm showing you the reconstruction from the front. I've taken away all the developing pericardium. I've taken away the developing jelly that is surrounding the endothelial heart tube, just to show you the cavities. And you can now see that the heart tube is beginning to bend. The venous inflows have been reconstructed in blue. And now that initial part of the linear heart tube, which eventually will form the left ventricle, is showing a bend. And at the cranial end of it, it is supporting the outflow tract. So now the vitelline veins, the hepatic veins, the vitelline veins and the umbilical veins rather have come together on each side. There is still symmetry at this stage of development. They are coming together to form the venous inflows. The vitelline veins, the umbilical veins have joined together. But if I now turn the same embryo and we look at it from behind, we can begin to see the third crucial venous plexus, because now we see the cardinal veins. And the cardinal veins are bringing the blood back from the head end, tail end of the developing embryo. As yet, however, they still have no direct connection to the venous inflows. But as we go one stage further, Carnegie stage 12, now for the first time, we see something that is beginning to resemble the definitive heart. I'm showing it to you from the front again, and very shortly I'm going to take away the ventricular, the atrial, and the outflow parts of the heart, so you can see what's happening at the venous pole. But as we look at it from the front now, we can see that the apical component of what will become the left ventricle is growing out from that inlet part of the ventricular loop. And this growing out process we call ballooning. This is another of the terms that was introduced by the team working in Amsterdam by Anton Moerman, Vincent Christoffels, who followed Wout Lammers into the Department of Anatomy in Amsterdam. And they introduced this notion of ballooning of the chambers of the heart. So the apical part of the left ventricle is ballooning from the inlet of the ventricular loop. The apical part of the right ventricle is ballooning from the outlet. And at this early stage of development, we have double inlet left ventricle because the atrioventricular canal empties only to the left ventricle. We also have double outlet because the entirety of the outflow tract is supported by the developing right ventricle. We then move to the margins of the pericardial cavity. Beyond the margins of the pericardial cavity, we see the manifold. It's called the aortic sac. And then this reconstruction, Carnegie stage 12, shows you rather nicely the development of the pharyngeal arch arteries. And if any of you are interested in this part of development, you can go to my presentations now available for the Heart University, and I have a specific presentation that is concerned with development from the outflow tracts, as I have another one concerned with development of the ventricles. But for today, let us return to the venous pole of the heart. So this is the same reconstruction, but I've turned the reconstruction of the venous pole so that you can see it from behind. And so now in blue, Wout and Jill have segmented and reconstructed the developing atrial component of that primary heart tube. And at this stage, we have an atrial cavity that is common to both the right and left sides. And the systemic veins are draining in symmetrical fashion to this developing atrial chamber. The atrial chamber, however, has retained its connection at this stage to what we call the pharyngeal mesenchyme. So in this view, again, showing you the atrium, I've blown it up so that you can see more what's going on. Again, we're looking at it from behind. I've tilted the reconstruction so that we're looking at it marginally from the right side. But what we can now see is the area over which the atrial component retains its connection to the pharyngeal mesenchyme. And this is very important because this connection, which we can think of as the heart stalk or the dorsal mesocardium, will become the entrance for the pulmonary vein. And it's important to note that from the outset, the dorsal mesocardium is discrete from the venous inflows. We can now distinguish these symmetrical venous inflows in terms of the left sinus horn, the right sinus horn, and now on each side, the cardinal veins have attained their connection to these venous inflows. The umbilical and the venous veins still come together through the hepatocardiac channels. So here we have the symmetry of the venous inflows with the venous return from both sides of the body coming on either side to the sinus horns, that then in turn drains symmetrically into the developing atrium. Now this is a comparable reconstruction made just one stage later. And you see now the fundamental change that takes place during development of the venous pole of the heart. We can now distinguish between the left atrium and the right atrium, but the key now is that the systemic venous sinus has changed, has moved, so that now it opens only to the cavity of the right side of what initially was a common atrial chamber. We also at this stage see venous valves that mark the boundary between the systemic venous sinus and the atrial component of the initial primary heart tube. So what you see now, as we look at it from behind, we can still recognize the site of the dorsal mesocardium. The drainage from the systemic veins is now entirely to the right. To your right hand, remember we're looking at the reconstruction from behind. The veins are draining only to the right side of what initially was a common atrial chamber. Now Wout and Jill have also reconstructed a tiny little pit within the dorsal mesocardium. And this pit is better seen from the inside. It is between two folds that I'm going to show you very shortly, and that pit will be the site where eventually the pulmonary vein opens into the atrial cavity. But when we now look at the venous inflows, you see that the left sinus horn is no longer draining into the atrial cavity. And that is because it is being incorporated into the developing left atrioventricular junction. And we can see how that happens rather nicely when we take an episcopic data set. This is from a data set of a human embryo that's been reconstructed by another researcher I've been collaborating with called Tim Mohan. Tim Mohan initially worked at the Crick Institute. Like myself, he has recently retired. But he has produced a whole series of embryos that he's reconstructed in 3 dimensions. And we can cut these any way we want. And I've cut this so that you're looking at the atrial cavities now from the front. And now looking at it from the front, so you're looking at the back wall of the developing atrial chambers, you can see those valves that now mark the boundary between the systemic venous sinus and the right side of the developing atrial chambers. And what you can see opening in to the systemic venous sinus is the opening of the superior cardinal vein, which will become the superior caval vein, and the opening of the right hepatocardiac channel, which will become the opening of the inferior caval vein. But what we can also see now is that the left sinus horn, retaining its own wall, has incorporated itself into what will become the left atrioventricular junction. And that also now opens to the right side of the atrial chambers, and that permits growth of the primary atrial septum, and you see here the beginning of the growth of the primary atrial septum, which can now grow down, putting the systemic venous sinus to the right side of the developing atrial chambers. And so now, if I show you what that looks like from the front, and Jill and Wout have now reconstructed also the venous valves, they're showing those in purple. This is one stage later. So there are the venous valves, and they are enclosing the opening of the systemic venous sinus. Because now, growing through the right side of that dorsal mesocardium, we have further ingrowth of tissues that separate the right from the left atrial chambers. And this is the vestibulous spine, the spina vestibuli, first described, in fact, in the middle of the 19th century. And it is the growth of the vestibulous spine that commits the pulmonary vein to the developing left atrium. With regard to the systemic veins, we can now see the communication that brings all the left-sided venous return to the right. This is the venous duct, the ductus venosus, if you will. And this development of anastomosis means that all of the blood that initially was bilaterally symmetrical is now coming to the right side of the developing atrial chamber. And the venous duct, of course, will drain the blood from the umbilical vein and the vitelline vein. The superior caval vein, as you have left superior caval vein, as you've seen, drains through the left sinus horn, and that has also been incorporated so that it drains to the right side of the atrial chambers. So if we now go on quite a bit, we're looking now at the stage where atrial septation is complete, because now we can see how everything is coming to the developing right atrium. We're looking at the situation again from behind. So that is the back of the right atrium. And here you will see the development of what will become the terminal crest and the terminal groove. And within there, we see the cavity of the systemic venous sinus. And coming into it, at this stage, completion of atrial septation, we now have the superior caval vein. The left superior caval vein continues to drain through the left sinus horn, which is now becoming the coronary sinus. Coming into the systemic venous sinus from beneath, we have the inferior caval vein, but there are also a series of venous collateral channels which produce the Hazardous veins, and they drain into the superior caval vein. And that is going to be important as we consider the relationship between the drainage of the venous blood from the abdomen, on the one hand, through what will be the inferior caval vein, on the other hand, through the Hazardous system of veins. Now, however, you can see the pulmonary veins. Is the pulmonary vein derived from the systemic venous sinus? This remains a bone of contention. So let me take you back to Carnegie stage 14. I'm showing you now again the venous structure seen from the right side, because this is the first time that we can see both the systemic venous sinus and the pulmonary veins. And at the first stage, we see development of the pulmonary vein. It is discrete from those venous valves that mark the junction between the systemic venous sinus and the developing right atrium. And in fact, we now know that the pulmonary vein had nothing to do with the systemic venous sinus. This is work I did with Antoon Moorman while he was still working at the University of Amsterdam. There was a young fellow who did this work called Alexander Sizarov. Alexander is now a pediatric cardiologist working in Maastricht, but he did this very elegant work where he was able to stain serial sections from human embryos. And the serial sections were directly adjacent one to the other. And this section he has stained to show the NKX gene. And the NKX gene, which is shown in reddish purple, stains all the myocardium of the developing atrial chambers, but it does not stain the systemic venous sinus on the right side, nor the myocardium of the left sinus horn. But what Alexander's section showed us is these two ridges that now mark the site of entrance of the pulmonary vein into what will become the left atrium. And so this is the adjacent section to that one that Alexander has now stained with the TBX gene. And the TBX gene does mark the systemic venous myocardium. So there you see the systemic venous myocardium, the superior caval vein on the right, also the myocardium of the left sinus horn. What it does not stain is the opening of the pulmonary vein to the left atrium. So this is additional evidence to confirm that the pulmonary vein has nothing to do with the systemic venous sinus. In fact, we know that the pulmonary veins themselves develop within the lungs. And we also now know that a strand that initially forms within the midline of the pharyngeal mesenchyme canalizes to produce the connection between those intraparenchymal pulmonary veins and the cavity of the left atrium. And that strand never has connections with the systemic venous sinus, but there are collateral channels that potentially can connect those intrapulmonary veins with systemic veins should that midpharyngeal strand not canalize. And that is why, in absence of canalization of the midpharyngeal strand, we can have the venous anomalies I'm going to describe to you. But we also know the importance of that structure I've introduced you to already, the vestibulous spine, because it is the vestibulous spine, the spina vestibuli, described by Wilhelm His the Elder in 1865. Here is Hiss's drawing from the middle of the 19th century showing us that growth of the vestibulous spine. It is the growth of the vestibulous spine that commits the pulmonary vein to the left atrium. And I can show that to you in this very nice histologic section. This is a 4-chamber section. The fortunate thing for those of you who understand echocardiography is that you can now understand cardiac development, because it's an easy matter, I hope, to see the developing right atrium, right ventricle, left atrium. What we see here in the multi-speckled tissue is how the tissue from the pharyngeal mesenchyme here is growing into the heart, fusing with the inferior atrioventricular cushion and committing the pulmonary vein to the developing left atrium. And there is the cavity of the left atrium. And it's only later that the pulmonary veins then begin to migrate so that they achieve their definitive position on the roof of the left atrium. So here is a later stage, and now you see the pulmonary venous component beginning to expand. Again, you see it's the equivalent of a 4-chamber section. There is the pulmonary venous component now coming into the left atrium, and it is only at this stage, as the pulmonary veins gain their attachment to the atrial roof, that we see the superior interatrial fold. This is often said to be the septum secundum. In fact, it is not a septum at all, it is a fold, but it produces the superior rim of the oval foramen. Note as we pass that the left superior caval vein retains its own walls and interposes between the pulmonary veins and what I'm going to show you shortly, the left atrial appendage. So there we see the development of the normal veno-atrial connections. It's also important for you to appreciate that this normal arrangement can only be seen when we have usual atrial arrangement. So when you begin to consider abnormal veno-atrial connections, the first thing you have to do is to ensure normality, and that means establishing that there is usual atrial arrangement. And we now know, I'm sure you all appreciate this, that we do this by looking at the extent of the pectinate muscles, because the shape of the appendages can be changed by abnormal hemodynamics. But if we look inside the atrial chambers, and we look at the relationship of the pectinate muscles to the atrioventricular junctions. And increasingly now it is becoming evident that you can see this with the techniques that you have at your fingertips in the clinical setting. Here in the heart itself, you're looking down on the tricuspid valvar orifice, and you see how the pectinate muscles extend round the junction, reach to the crux. On the left side, in contrast, the vestibule is smooth. The pectinate muscles are confined within the atrial appendage. And as I say, nowadays, with computed tomography, increasingly also with echocardiography, you can see this. So here in this exquisite picture where you are looking at the right atrioventricular junction from the ventricular aspect, you see the triangular right atrial appendage, terminal crest, but look how you can also recognize the pectinate muscles. And from this same patient, when we look at the other side, you see the tubular appendage, the pectinate muscles confined within the appendage, the smooth posterior vestibule. And these exquisite images were prepared by a young colleague of mine working at the All India Institute of Medical Sciences in New Delhi, Saurabh Gupta. And Saurabh has prepared these images from a computed tomographic data set available to him, but he's done it using HOROS technology, HOROS software, which is freely available, and he's done this on his Mac. So now, according to Saurabh, any of you, providing you have access to a Mac, you can download the HOROS software, and you can yourselves manipulate these amazing computed tomographic data sets that permit you to understand normal venoatrial anatomy. But even if you are concentrating on echocardiography, there is now an additional feature that permits you to distinguish what is morphologically right, what is morphologically left. And that is the presence of the coronary sinus within the left atrioventricular groove. So if you see a venous channel in that left atrioventricular groove, there has to be either usual atrial arrangement or else left isomerism of the left atrial appendages. Because we know the coronary sinus is always absent in the setting of right isomerism. And if there was mirror imaged atrial arrangement, then the venous channel would be in the right-sided atrioventricular junction. So now I firmly believe that with the techniques you have at your fingertips, it should always be possible for you to establish the specific atrial arrangement to distinguish the morphologically right from the morphologically left atrium. So once you know that you're dealing with a morphologically right atrium, you can then look for the veins that should be opening within the confines of the systemic venous sinus. And you'll now be aware that we should be finding superior and the inferior caval veins along with the coronary sinus. So if I represent this normal arrangement to you in diagrammatic fashion, there you see the superior caval vein. We expect it to receiving the brachiocephalic vein, so the blood is all being shunted to the right side, and it will also receive the Hazardous vein that is bringing the blood back from the thoracic, the parietal parts of the thoracic cavity. And it, together with the inferior caval vein, which drains the hepatic veins, and also the coronary sinus, will open to the smooth-walled systemic venous sinus. Now, there is the track of what initially was the left superior caval vein, which is the remnant of the left superior cardinal vein. And there is an important relationship between the left-sided pulmonary veins, the left atrial appendage, because always, if it is present, the persistent left superior caval vein will track down between the left atrial appendage and the left pulmonary veins, as I am going to show you very shortly. So any of those venous channels can be abnormal. So now we are in the position to begin to consider abnormal venoatrial connections. Exceedingly rarely, you can have totally anomalous systemic venous connection. In fact, I've never seen myself a heart with this arrangement, but Saurabh Gupta has found several examples in his experience in the All India Institute. But more usually, we're going to be looking for anomalies of the superior caval vein. Rarely that. The right superior caval vein can drain to the left atrium. That is one of the steps towards totally anomalous systemic venous connection. That is rare. It can also be absent. But the one that we should be concentrating upon is persistence of the left superior caval vein. The inferior caval vein can be abnormal. That also, on occasion, can drain directly to the left atrium. That is unusual. The one we should be thinking about here is for interruption of that inferior caval vein. And then, because as I've shown you, the Hazardous system provides collateral channels to get the blood back into the superior caval vein, we have return through the Hazardous system. And then, of course, there are the abnormalities of the coronary sinus. Its walls can be fenestrated, they can be completely unroofed, but more usually, coronary sinus functions to drain the persistent left superior caval vein. And then we must not forget this additional channel that we call the levo-atrial cardinal vein. So let's look at these in detail, and let's start with the commonest, persistence of the left superior caval vein. So I'm showing you this heart from behind. And there you see the persistent channel, which is the left superior caval vein. It's opening to the right side of the heart through the enlarged orifice of the coronary sinus, and it is tracking down behind the left atrium, and it is doing so between the left pulmonary veins and the left atrial appendage. And this is the characteristic track for the persistent left superior caval vein, and it matches that track I showed you as the left sinus horn became incorporated into the left atrioventricular junction. Now, significantly, it has its own walls. And so there are separate walls when we have persistence of the left superior caval vein, as we see here viewed at the right side. I'm showing you there the right pulmonary veins. There is a deficient oval fossa. And here, the left caval vein is opening to the right atrium through the enlarged mouth of the coronary sinus. And that is the commonest of the anomalies of the superior caval vein. And I'm dealing with the common systems first. So when we look at the inferior caval vein, let's forget for a moment the inferior caval vein coming to the left atrium. It can exist, but it is very rare. It's associated with a sinus venosus defect. But we need to distinguish that from persistence of the eustachian valve, because that can deflect the inferior caval vein into the left atrium. But much more frequent is to find anomalies of the inferior caval vein when it is interrupted with azygous continuation. And here again, you must make sure you're dealing with usual atrial arrangement, because the frequent association between azygous continuation is with left isomerism. But it can be seen with usual arrangement. So let me divert for just a moment and take you back to totally anomalous systemic venous connection, because I've now also introduced you to the sinus venosus defect. Now, perhaps many of you still think of the sinus venosus defect as an atrial septal defect. It is not. It is an interatrial communication, but one that can only coexist with an anomalous pulmonary vein. So that's why it's important to think of this as we discuss anomalous venous connections. And it is in the presence of such an anomalous venous connection, part and parcel of the sinus venosus defect, that in an extreme form can permit the venous valves to sequestrate the entirety of the systemic venous sinus into the left atrium. Because when we look at partial anomalous pulmonary venous connection, I'll come back to this very shortly, but you're looking at this from the right side. There is the right atrial appendage, and there is a right upper pulmonary vein that is draining anomalously into the superior caval vein. The right lower pulmonary vein, along with all the left veins, is draining into the left atrium. And I show you this because I want you to compare it with this arrangement. Again, we're looking at it from the right side, but this time I've opened out the junction between the superior caval vein and the right atrium. The lower pulmonary veins from the right side are still connecting into the left atrium, but the upper vein is draining anomalously into the superior caval vein, but it is creating a defect that is well away from the oval fossa, and that defect is the sinus venosus defect. The right upper pulmonary vein has drained anomalously to the superior caval vein whilst retaining its connection to the left atrium. There are the left and right lower pulmonary veins normally connected, but there is the lower vein attached to both right and left atriums. Sorry, it should be the right upper vein attached to both right and left atriums that has created this channel between the atrial chambers. And in the extreme form, the entirety of the systemic venous sinus can be connected to the left atrium through what in essence is a sinus venosus defect, with the remainder of the atrial septum being intact. So let me now divert again and show you how the inferior caval vein can be diverted into the left atrium through a persisting eustachian valve. It's key to distinguish this and to recognize that the eustachian valve is not part of the atrial septum, because in certain circumstances, the space between the eustachian valve and the atrial septum can be considered to represent an interatrial communication, and if that is patched, the inferior caval vein can be connected incorrectly into the left atrium. But much more frequently, much less frequently, we can have that rare arrangement in the setting of an inferior sinus venosus defect, where with an anomalous pulmonary venous connection, the inferior caval vein can be directly connected to the left atrium. This one is rare. Let's return for a moment to azygous continuation, because here you see a case in which there is usual atrial arrangement, because there is the morphologically right appendage. So we can have azygous return to the superior caval vein with interruption of the inferior caval vein in the setting of usual atrial arrangement. But this is rare. Much more frequently, it is found with left isomerism. But let me return for just a moment to anomalies of the coronary sinus. Persistent left superior caval vein is part and parcel of this, but that permits us to understand what can go on with fenestration and then with unroofing of the coronary sinus. And then I'll show you the levoatrial cardinal vein. So this is the start of unroofing of the coronary sinus. I'm showing you the heart from behind, and I'm showing you the track of that coronary sinus within the left atrioventricular junction. So there is the start of the coronary sinus, there is the cavity of the left atrium, and there are two fenestrations that permit the coronary sinus to drain directly into the left atrium. Now, we don't know why these fenestrations occur, because usually, as you see here, the coronary sinus has its own wall that is discrete from the wall of the left atrium. So these fenestrations have to produce windows through both of these walls. But when they do so, those walls themselves can disappear, and they leave this arrangement, which is the coronary sinus defect. So there is the mouth of the left superior caval vein. It's now coming into the roof of the left atrium, between the appendage and the left pulmonary veins. And now, because both of those walls have disappeared, the mouth of the coronary sinus will function as an interatrial communication. The walls have disappeared, but it is not an atrial septal defect. So this is the levoatrial cardinal vein, so-called. In reality, it is neither levoatrial nor cardinal. It is an anomalous channel that connects the pulmonary veins to the superior caval vein, seen most frequently in the setting of hypoplastic left heart syndrome. And here is one such example where from the roof of the left atrium, draining the pulmonary veins, is a channel that weaves itself behind the superior caval vein, providing an overflow for the left atrium and draining into the superior caval vein. So let me now switch horses, as it were, and let's look at the normal connections to the left atrium. Because usually we have 4 pulmonary veins coming to the atrial roof, 2 on each side. Remember the track, the left superior caval vein, which usually drains to the coronary sinus, but in most instances disappears. When we consider the anomalous venoatrial connections, we also need to consider the arrangement of the atrial septum. Because the floor of the atrial septum is the flap valve, and that is the primary atrial septum. The true second atrial septum is this anteroinferior buttress. And there is a deep groove between the openings of the right pulmonary veins into the left atrium, the superior caval vein into the right atrium. And I hope by now you all realize that the so-called septum secundum in reality is the superior interatrial fold. Now, when we are looking at anomalous pulmonary veins, we need to distinguish between anomalous connections and anomalous drainage. So the veins can be normally connected, but still drain anomalously, and we've seen that already in the setting of the levoatrial cardinal vein. We see it also with fenestrations of the coronary sinus. So when we describe the connections, we must first determine whether they are normal or anomalous, and then distinguish that from potentially anomalous drainage. But remember again, the normal pulmonary venous connections are sandwiched between the connections of the right-sided veins to the systemic channel and the coronary sinus, which represents the left superior caval vein initially. So if the pulmonary veins do drain anomalously, they can do so in total fashion, and that happens when all of both lungs drain anomalously. They can do so in such a way that only one of the lungs drains anomalously, and that is unilateral anomalous connection. But also we can have partially anomalous connection, part of one lung or part of both lungs draining anomalously, and of course we can have any combination of the above. So when we think of these anomalous connections, we then have to think, where do they drain? And they can drain above the diaphragm to the superior caval vein, to the Hazardous vein, or they can drain to the coronary sinus, and the coronary sinus will then drain into the right atrium. The veins can drain directly to the atrial chambers, but that is very unusual, except in the setting of right isomerism. The other variant, of course, is diaphragmatic and intracardiac, and that typically occurs through the portal venous system, although very rarely it can drain directly into the inferior caval vein, although I have never seen that. So let's not forget partially anomalous connections, the scimitar syndrome. Let's also remember the sinus venosus communication, where partially anomalous connection is the phenotypic feature now of these defects, and that can go to various parts. If there is a sinus venosus defect in between, that can lead us towards totally anomalous systemic venous connection. But we only find those sinus venosus communications when the ovifossa itself is intact, because the sinus venosus defect is a venous malformation. And as I say, it is part of the substrate of totally anomalous systemic venous connection. So what we need to concentrate upon is totally anomalous connections, and I've shown you all these, the variations that we need to know where they drain. And so this is the typical supracardiac connection. The veins are coming together to form a confluence. Typically, they then continue through an ascending channel which is left-sided, which drains into the brachiocephalic vein and then into the superior caval vein. So when we look at it from the front, we see the typical snowman arrangement, with the ventricular mass forming the body of the snowman, the ascending vein, the brachiocephalic vein, superior caval vein forming the head of the snowman. And this is what it looks like from behind, the ventricular mass forming the body, the venous channels themselves forming the head of the snowman. On occasion, however, the veins can turn the other way round. This is a much rarer form of supracardiac drainage. So the left veins this time are crossing in horizontal fashion. They're picking up the right veins as they ascend in the right paravertebral gutter, and then typically they drain into the Hazardous vein and thence into the superior caval vein. Cardiac connection directly to the right atrium is the typical situation when we have left isomerism with veins on either side, so that's not really an anomalous connection, but we see this most usually when we have right isomerism. And it is rare with usual atrial arrangement, because then cardiac connection is typically via the left superior caval vein, as you see here. And now again, we have the dual walls between the left atrium and the pulmonary veins that are connecting into the coronary sinus and thence into the right atrium. So if you have direct connections, as you see here, you should anticipate right isomerism. And this is a case of right isomerism, and the phenotypic feature is absence of the coronary sinus, with the veins draining into an atrial chamber possessing a morphologically right appendage. But more usually in the setting of right isomerism, and here very nicely you see the isomeric right appendages, this time with double inlet to a dominant left ventricle, we have again absence of the coronary sinus, the anomalous veins now draining through a midline channel into the roof of the bilaterally symmetrical atrial appendages, draining themselves into the common atrial chamber. So finally, infradiaphragmatic and infracardiac connection, usually to the portal venous system, and there the key is obstruction after closure of the venous duct. So it is exceedingly rare to find direct drainage directly to the inferior caval vein. This is the feature of anomalous connection, and what I've done here is to do the so-called Tausig Maneuver. It was Helen Tausig who pointed out that in the setting of totally anomalous pulmonary venous connection, you could flick the heart out of its pericardial cradle because there was no connection between the pulmonary veins and the left atrium. And having done that, in this instance, you see the body of the left atrium separate from the confluence, but this time the vertical vein is turning downwards, passing down into the abdomen and joining the portal venous system. And that is why you get obstructed drainage in this instance, because whenever the venous duct closes, the blood has to go through the liver. You can also have obstructed drainage in other situations, much rarer. Drainage to the coronary sinus can be obstructed by a Thebesian vein. You can have it with supracardiac connection when you have the so-called bronchopulmonary vice, when the channel passes between the pulmonary artery and one of the bronchuses, as you see here. There are the pulmonary arteries, there the bronchus, and in this instance, the supracardiac channel is obstructed as it passes through the bronchopulmonary vice. So to summarize everything, I've told you rather a lot today. There's a lot to get on board. But what I hope I've shown you is that if now you understand the normal development That gives you the basis for understanding all these potential variants. Also, you need to take into consideration normal anatomy, key to distinguish between usual arrangement, the finding of isomerism. The anomalous connections can exist themselves in isolation, or they can be part and parcel of many other associated lesions. But whenever you have multiple anomalous venous connections, always you should be suspecting isomerism of the atrial appendages.